Good day to our respected lecturer and my fellow peers. My name is Wan Mastulina Isati binti Trimo. My metric number is 080092, and today I will be presenting an image critique of elbow radiography using PESMAN framework. The primary focus of this presentation is to evaluate the technical quality of the radiography while highlighting the radiographic appearance and pathology of synovial osteochondromatosis. So moving on to the next slide, let's look at the definition of synovial osteochondromatosis. This is a rare benign disorder where the synovial membrane undergoes metaplasia, producing multiple cartilaginous nodules inside the joint. Over time, these nodules can detach, become loose bodies, and calcify, and also appearing as multiple rounded calcification on radiographic images. While it commonly affects large joints like the knee or hip, in our case, it involves the elbow. Patients typically present with a pain, swelling, stiffness, and joint locking. An epi and lateral elbow radiograph is essential to demonstrate this calcified loose body and evaluate the joint involvement. Moving on to this slide, we look at the side-by-side comparison under the title Normal versus Synovial Osteochondromatosis Radiograph. On the left, we can observe a normal epi-elbow radiograph showing a clear, unobstructed joint spaces and a smooth cortical outline. In stark contrast, the radiograph on the right displays an epi-elbow presentation with a synovial osteochondromatosis characterized by a multiple calcified or ossified loose bodies and clustered extensively within and around the elbow joint capsule, which significantly impact a normal joint structure and mobility. So next, this is the radiographic appearance of normal epi-elbow X-ray. Based on our critique, the distal humerus, proximal radius, and proximal ulna demonstrate a normal anatomical alignment with a well-maintained alignment joint space. The cortical margin of all visualized bones are intact with no evidence of fracture or dislocation, and the trabecular pattern appears entire normal. Furthermore, the surrounding tissue are unremarkable, showing no joint effusion or displacement of fat bed. Overall, this radiograph is within a normal limit. Now, we look at the radiographic appearance of synovial osteochondromatosis in a left epi-elbow projection. The radiographic clearly demonstrated multiple well-defined rounded and calcified loose body clustering within and around the humeroulnar and humeroradial joint spaces, varying in size, a characteristic ring and arch or target like a mineralization pattern. This is also associated widening and remodeling of the olecranon and coronoid fossae to accommodate these large nodule masses, along with secondary degenerative changes like a joint space narrowing and marginal osteocyte formation. Finally, significant soft tissue distension is present due to extensive nodular proliferation, making this highly characteristic of advanced synovial osteochondromatosis of the elbow. So moving on to the next slide, we have now entered the first element of our PESMAN criteria, which is P for projection. This is an epi-elbow radiograph confirmed because the medial and lateral humeral epicondyle are demonstrated in profile. The radius and ulna are clearly visualized, and entire elbow joint is included. Ultimately, this epi projection adequately demonstrated the distribution of the intra-articular calcified nodules and the associated degenerative changes caused by synovial osteochondromatosis. For this slide, we can observe the label anatomy on epi-elbow radiograph to further support our projection criteria. On the medial side, we can clearly identify the humerus, medial epicondyle, trochlea, coronoid process, radial tuberosity, and the ulna. On the lateral side, the landmark visualized include the olecranon fossa, lateral epicondyle, olecranon, capitulum, radial head, radial neck, and radius. We now look at our second criteria in PESMAN, which is positioning. Evidence of correct positioning is shown as distal humeral, radial head, radial neck, proximal ulna, and also olecranon process are all demonstrated with the medial and lateral epicondyle clearly seen in profile and elbow joint fully visualized. However, note that while the olecranon is situated within the olecranon fossa, it is obscured by calcification due to synovial osteochondromatosis. Finally, multiple well-defined rounded, calcified, loose body are seen within and around the elbow joint. So for this slide, we focus on positioning assessment, where a notable positioning error is present. The elbow demonstrated internal rotation because the radial head is excessively superimposed on the ulna, showing an overlap greater than standard 0.6 cm parameter, and the radius and ulna do not appear perfectly parallel. To improve this positioning, we suggest externally rotate patient arm slightly until the humeral epicondyle are completely parallel to the image receptor, and carefully adjusting the position until approximately 0.6 cm or a quarter inch of the radial head overlap the ulna for a true epi profile. So now at the third criteria in placement, which is A for alignment. Specifically looking at the X-ray tube and IR, the alignment between X-ray tube and image receptor is correct because the distance between the superior and inferior edge of collimation and the edge of film is completely equidistant. Now we continue with alignment, focusing on the X-ray tube and patient. The alignment between the X-ray tube and patient is correct because the central point for this projection fall at a perpendicular angle to the IR, directed straight to the mid-elbow. As alignment is we look at the IR and patient. So this alignment is correct because the central point for the projection fall at a perpendicular angle to the IR, directed to the mid-elbow, which specifically lies 2 cm distal to the midpoint of an imaginary line drawn between the epicondyle. Moving on to the collimation, we evaluate C for collimation. A proper four-sided collimation is present on this image. The superior collimation correctly includes the distal humerus, while the inferior collimation includes the proximal quarter of the radial and ulna. Additionally, the lateral collimation includes lateral skin margin of the elbow, and the central ray remain directed perpendicular to the elbow joint. For this page, we cover E for exposure with a set factor of 50 to 60 kbp and 2 to 5 ms. Unfortunately, the kbp used is not adequate for proper penetration and the radiographic contrast, while the thin bony cortical outline density of the epicondyle is clearly seen. The thick olecranon region is not. Similarly, the ms is inadequate for a bony trabecular pattern visualization, as the trabecula are only clearly seen in the thin epicondyle but obscured in the thick olecranon. To improve this underpenetrated image, we should increase the kbp by 15% and increase the ms by half. For this slide, we look at the M for marker criteria. An anatomical marker is present on this radiograph, but it has been placed in a wrong position. For standard diagnostic compliance, the radiograph should ideally have the right or left anatomical marker placed neatly at upper corner of the image instead of along the side anatomy. So now we look at the A for aesthetic. The film size used is 24 times 30 cm. Orientation is lengthwise. From a technical standpoint, no motion artifact is demonstrated, and both bony corticus and visible trabecular marking appear sharp. So in this slide, we address N for name or patient identification. Essential details such as name of patient, the registration number or patient ID, the date of examination, and the institution or hospital name are completely missing from the film. For a complete democratic record, this information should be clearly located at the inferior border of the radiograph. So finally, for this slide, my conclusion is I must reject this radiograph. This rejection is due to three main reasons. First is the anatomical marker is present but placed incorrectly. Second, the image demonstrated mild internal rotation of the elbow as evident by excessive superimposition of radial head on the ulna. And third, the radiograph is technically underpenetrated, meaning the exposure factor used were not adequate for a diagnostic view. We evaluate the P for projection criteria. This is lateral elbow X-ray, which should ideally show the joint flex at approximately 19 degrees with the radial head and coronoid process superimposed. However, in this film, we see severe crowding and dense calcification arising from a synovial osteochondromatosis, which physically obscure and overlap the humeroradial and humeroulnar joint spaces, completely blocking the standard open joint space presentation. Despite the pathology, we can still identify several key anatomical structures on this lateral projection, including the distal humerus, the coronoid fossa, the olecranon process and its fossa, the trochlea, as well as the proximal radius and ulna, highlighting the radial head, neck, and tuberosity. Next, we cover P for positioning, looking at the evidence of correct setup. Under normal circumstances, a true lateral view is evidenced by olecranon process of the ulna visualized clearly in profile, projecting fully away from the humerus alongside a partially overlap of the radial head over the coronoid process and the radial tuberosity directed anteriorly. However, as we can see at the past slide, there is noticeable positioning error in this film. The elbow forms an approximate 80 to 85 degree angle rather than 90 degree flexion. Furthermore, the distal humeral and forearm are externally rotated, which is clearly evidenced by a deep separation of the distal humeral condyle, appearing as a two distinct concentric posterior arch instead of single smooth contour, and radial head being shifted too far posteriorly beneath the ulna. To correct this error, we must ensure the patient hand is rotated internally from open position into a straight lateral position with a thumb pointing straight up toward the ceiling to prevent the forearm bone from pronating or rolling upward. Additionally, we should lower the radiographic table or sit the patient lower to ensure the shoulder, elbow, and wrist lie flat in exact same horizontal plane, avoiding any tilt or the distal humerus. Now we look at the A for alignment, specifically between the X-ray tube and IR. This aspect of alignment is correct because the distance between the superior and inferior edge of collimation and the edge of film is perfectly equidistant. For this slide, we assess the alignment between X-ray tube and patient. In this case, the alignment is incorrect because the centering point falls at the superior and anterior to the true elbow joint space, meaning the central ray was not directed accurately to the midpoint of the joint complex. Now we look at the suggestion for improvement regarding alignment. To correct the alignment error, we must move the patient's actual elbow joint slightly superiorly and anteriorly toward the center of X-ray tube and image receptor. For this slide, we evaluate C for collimation. A proper four-sided collimation is neatly demonstrated on this film. The superior collimation properly includes the distal humerus. The inferior collimation safely encompasses the olecranon process, and the lateral collimation correctly captures the soft tissue and lateral skin margin of the elbow, while keeping the central ray directed perpendicular to the joint space. On this slide, we address E for exposure with a set factor of 55 to 65 kpp and 3 to 6 ms. Looking at the bony cortical outline density, the thin fat pad and thick olecranon process are clearly visualized. However, the kpp used is overexposed for a proper radiographic contrast penetration. Because of this overexposure and pathology like a displaced fat pad or cell sign should be visible in the radiograph, but it's completely burned out, meaning we must increase the kpp by 15%. For the bony trabecular pattern contrast, the markings are clear at the thin olecranon process but overexposed at the thick coronoid, though the MAS factor remains generally adequate for penetration. Next, we cover M for marker criteria. There is absolutely no marker present anywhere on this radiograph. For standard medical and legal validation, the radiograph should ideally have a right or left anatomical marker placed accurately at the upper corner of the image. Moving on to this slide, we evaluate A for aesthetic. The film used is 24 x 30 cm oriented lengthwise. From a technical standpoint, no motion artifact is demonstrated, meaning the patient remaining perfectly still during the exposure, providing a sharp structural outline. For this slide, we look at the N for name, representing patient identification, essential demographic detail, including the patient name, the registration number for ID, the date of examination, and the institution or clinical name are completely missing from this film. For a complete record, this required information should be neatly located at the inferior border of the radiograph. So finally, for this slide, my conclusion is I must officially reject this radiograph based on three critical failures. First is there's no anatomical marker present on the film. Second, the radiograph demonstrates an internal rotation error as evidenced by a deep separation of distal humeral condyle. And the third is the radiograph is technically overpenetrated, rendering the final image inadequate for standard diagnostic compliance. Finally, we have reached the last slide. Thank you very much for your time and attention throughout this presentation.